Hi, I'm going to be talking today about some considerations for implementation science study designs. I am not going to cover every possible design, but talk about some issues in selecting designs and considering designs and give you some examples. The first thing I want to mention is this work by Russ Glasgow and David Chambers in really trying to identify dissemination implementation science characteristics and what that means for study designs. In contrast to studying an intervention, an efficacy or effectiveness trial, we really have a broader purview of things to think about. You can see in this table, that it's often a systems perspective, that context in which we're implementing is critical. This is often multi-level and complex. So there's a focus not only on intervention, on providers, but also on organizations and systems, that we have kind of robust and practical goals. We want our work to be generalizable, meaningful, usable, and scalable. That our research methods should be used to enhance relevance. So we want to be rigorous, yes, but we also want to be efficient and often to be adaptive in what we're doing and capture those adaptations. And I'll talk about that a little bit more later on. And often integration of methods for triangulation and understanding the context of implementation. And we want to be relevant for not just research, not just for publishing in a journal, but also for the stakeholders that might find some utility in the work that we're doing in implementation science. Our system leaders, organization leaders, clinical providers, patients, and clients who we might serve. The upshot is that we need to be flexible in thinking about dissemination, implementation, research, and study designs. This question, what is the best design to use? Well, it depends on a lot of those issues that I mentioned, the context, the innovation, the strategy that's being used to implement. And many study designs can be used in implementation research, and most designs are not unique. They are well established, come from other disciplines, and we apply them in implementation science. And this includes observational methods, experimental, quasi-experimental, mixed methods, etc. However, there are some exceptions. This idea of effectiveness implementation, hybrid designs that I'll talk about a little bit more. In a new development, this idea of scaling out that I'll talk about, or comparing new research to existing data from other trials. As I mentioned in that first slide, often implementation is multi-level, and we ignore that to our own peril. Interventions and implementation happens within broad systems. This could be statewide, county systems, health systems, hospital systems. So we need to understand the organization, policy context, and what leaders and others are doing, the agents and agency of how implementation happens. We need to think about those, what we call outer context of the system, inner context of organizations, the bridging factors that link those contexts as we think about this. Implementation science is system-oriented, multiple components, multiple stakeholders, dynamic, that it operates usually through phases of a process. And there have been recent developments in measures such as the stages of implementation completion to address that and to assess it. And that in design, we have to be thinking about our implementation strategies, how we're going to test those, and at what level. Is it a team level, or is it at an organization level, or is it more broadly at community or state levels? But implementation process is measurable. And you'll see in my slides that I have references and you can find more detail. So in selecting study design, we have these overarching issues, but many of those are very pragmatic. So we have our research question, we have the type of clinical intervention, the type of implementation strategy, but we also think, how feasible is this study going to be? What's it going to cost? In this setting, who are the important stakeholders? What are the logistics of rolling out? Who are our target populations? What's our timeline? Is this an implementation that's going to take 3 weeks, 6 months, 2 years? We have to be thinking about how the ethics and inclusivity of what we're doing and hearing our stakeholders and partners' voices and integrating that into our designs. And also, in addition to data that you may be collecting, is there a way to streamline what you're doing through available administrative data sets, system level data sets, hospital system, electronic health records? That will also also go into your design decisions. And not inconsequential is how we're going to fund this. And so if we're doing a smaller exploratory developmental grant that maybe has a 2-year window and limit on funds, your scope is going to be smaller, your timeline is going to be smaller. So as you're selecting your study designs, you're going to be thinking about that, as well as, if I'm going to do a larger multi-year study with a bigger budget, what are my options? So as we start talking about designs, we can think of designs we'll do within a site. So example, a post design to adopt an EBP in a new setting, or a pre-post design of an implementation strategy for an implementation that's in use. Can you bolster or improve the quality of what's being implemented? Between site designs are numerous, but it could be you're implementing a new implementation strategy versus implementation as usual in different sites. You could be doing a head-to-head randomized test of 2 or more implementation strategies. This is essentially comparative effectiveness of implementation strategies. You can be testing a suite of evidence-based interventions. In all of this, you can use factorial designs. You can also consider whether you need to randomize at one level in a nested design. For example, if you're randomizing clinicians to interventions, but you're randomizing clinical units to a implementation strategy, you may be randomizing at those multiple levels. So for example, in one study, my colleagues assigned regions in a state to evidence-based practice versus practice as usual, but then randomized within those regions to having facilitative coaching versus no coaching. And that was a study by Mark Chaffin and colleagues in Oklahoma. And you can do within and between site comparisons. You have a lot of options to consider. In experimental study designs, the usual suspects are the randomized controlled trial, but often in implementation research, we need to consider the cluster randomized controlled trial because our unit of analysis may be the clinic. It may be a child welfare team. It may be public health agencies in multiple states. So we can use these well-established designs in implementation studies. Then there's the idea of pragmatic RCTs that improve efficiency and moving forward with research and the impact of your research. And then designs like a Stepped-Wedge cluster randomized control trial where everybody may get the implementation strategy or intervention, but it will roll out in a design that allows for timing of implementation across different organizational units. Also important in implementation science is the opportunity for observational study designs, studying or assessing phenomena as it occurs naturally. So you can think of policy initiatives that roll out and how those affect the organizations and what that means for uptake of new innovations for quality improvement. The characteristic of these to note is that there may be no randomization and no manipulation. So we need to think about how those will really play out in our study design. For a cohort study, you may also not have control. You can maybe frame it as a multi-cohort and compare cohorts in a rollout type design, or you may have a cross-sectional study where your ability to infer causality is limited. But there are options for these designs, so I encourage you to look at observational designs, and some of the references that I have on this slide can give you some guidance. Important in implementation science is to think about integrating the implementation framework or model that you're using. I worked on developing the exploration, preparation, implementation, sustainment or EPIS framework, so I'm very familiar with utilizing that. And we think about some of the issues that I've already mentioned, understanding outer context of the systems, inner context of organizations, but also looking at what connects those as we implement interventions. It can be used in policy implementation as well. But the idea here is that we want to link our study design and the variables that we select back to our framework. And the one reference on this slide by Jenny Buchan is a really nice example of taking a large-scale trial with multiple NIH-funded centers and building those in a common implementation strategy using the framework to guide not only what is measured, how it's measured, and when it's measured, but also tracking progress through the phases of exploration. So this is a nice example. I mentioned pragmatic study designs, and this is some really nice work that's been done in the PRECIS model, the Pragmatic Explanatory Continuum continuum indicator summary. And this is a tool for thinking about how explanatory or pragmatic your study is going to be. And it's one way to frame a study as you're thinking about it. And there are 9 constructs in the Presses 2 model, thinking about eligibility, who's selected, how are participants recruited, what's being done in the trial, what expertise and resources are needed, the flexibility, how the intervention should be delivered, adherence to the intervention, follow-up, the main outcomes. And the idea of Presses is that as you move from the center, where it's very explanatory, think internal validity, you're moving more towards generalizability and external validity as you move through these different decision points in your study designs. I talked about RCTs and more controlled trials. I talked a little bit about observational, but what if you can't randomize to implementation conditions? What are some options? I mentioned the Stepped-Wedge cluster randomized control trial. And this type of study can be really useful, especially if, say, you're going to observe a system and your unit of analysis is substance use disorder treatment clinics in the system. But the system says, well, we want all of these clinics to have the benefit of the implementation strategy and the intervention. So what's the dilemma for us as researchers? Well, we can use the Stepped-Wedge design, where if you look on the left here, you have your participants in clusters. So you'll have 5 different rollout units. What happens is you start the intervention here in block 2 with one, in block 3 with another clinic, in block 4 with another clinic, in block 5 and 6, and so on. But the key here is that you're assessing the same implementation determinants or independent variables, mechanisms, the mediators and moderators, and the outcomes across all these. And you're measuring those determinants and mechanisms across most of the sites or all of the sites as you roll out. Some designs and benefits are that there's evidence in support of the intervention or resistance to parallel design. Like I mentioned, Stepped-Wedge design can be really useful. If the treatment is a service delivery or policy change, it doesn't necessarily require consent, but it's a naturalistic observational study. It's going to roll out as a service. But if you can work with a service system, work with organizations to say, well, we'll start these units first, these units second, et cetera, and you roll out. And this can increase efficiency over a parallel or a cluster randomized trial design. But, there are some things that you need. For example, you need a decent intra-cluster correlation and cluster size, number of people within clusters in a nested design. So it's difficult if you have low ICC cohort design and there are issues around data collection at the individual level, or if your clusters can't follow the randomization schedule. So in some cases, you may have, and this is a study by Patricia Chamberlain and Hendricks Brown and colleagues, they identified 40 counties to implement multidimensional treatment foster care with community development teams to help support that. Of course, at the beginning of the study, they had those who were ready and they had the timing. But as that changed, some of the readiness changed. And so there had to be re-randomization in the rollout design in the Stepped-Wedge. Here's another example of policy and health research protocol for Stepped-Wedge. Another interesting thing that I wanted to note here is that if you are also doing qualitative assessment, you can build that in to your Stepped-Wedge design. So, if you're starting with these first green blocks in Agency 1, you do some reassessment, some qualitative assessment as you roll out. You're still doing your measurement periods here in the white sections with your quantitative measurement, but you're able to integrate multiple methods in this. So there are a number of quasi-experimental study designs that you can also use if randomization is an issue. It's interrupted time series, also regression discontinuity designs, and non-equivalent control group designs. I think some groups wouldn't consider the gold standard, of a randomized trial or fully cluster randomized trial, but there are alternatives and some very strong alternatives for inferring causality. So one of those is the interrupted time series, which is really one of the strongest quasi-experimental designs. And it's also very useful in health system quality improvement. So if the implementation strategy is aimed at quality improvement, that can be really useful. Fortunately, there was a systematic review in 2020 by Hedegeka and colleagues that provides a lot of good background and information on the interrupted time series. But essentially, you have your measures and you have an observed slope of effect effect prior to the intervention. And you can see this dotted line here, before intervention to after intervention. And what you are looking for is whether or not there's a change in the level of effect and also a change in the slope or a trend that's observed after the intervention. This is a great design, for example, for a policy implementation or a large-scale implementation of a new approach or an implementation strategy to improve an existing clinical approach, where you've been able to observe some data prior to the intervention and also after the intervention. So that's one thing that's critical in this design. However, some caution is warranted. In the systematic review, you can see in this figure that there are an increasing number of studies per year, but the risk of bias is also kind of moderate to high across time. And the systematic review that I've cited here gives more detail on the nature of bias, type of bias, and how to avoid that issue. I wanted to talk briefly about some emerging and very innovative designs. The very first slide, Glasgow and Chambers, we talked about efficiency, and both the MOST and the SMART designs help us to learn more within a given study. And so for the MOST design, it's the process of identifying an intervention that provides the best expected outcome obtainable within key constraints imposed by the need for efficiency, economy, and scalability. This allows for testing not only intervention components, but also contextual constraints. If you think back to the EPIS framework, the CFER framework, REAIM, whatever framework kind of fits your thinking and what you want to use, you can be thinking not only of the intervention, but the contextual constraints that you want to understand and test along the way. In the classical RCT approach, you develop an intervention with the goal of demonstrating statistically and clinically significant effect in the RCT. For MOST, you want to build an intervention that meets predetermined standards of effectiveness, efficiency, cost effectiveness, and or scalability, and clinically significant effect. So we're thinking much more broadly about context, and that fits very well with thinking about how you're going to apply your implementation framework and helps in guiding thinking about what you need to consider. In Linda Collins' work on this, she identifies these different phases of the MOST strategy, the preparation, so laying the groundwork, thinking about the conceptual model, which is key, deriving or adapting your conceptual model, identifying the components, conducting pilot tests, identifying what optimization means in your criteria. And so in the optimization phase, you want to build that optimized intervention, really kind of have a moving process in which you can evaluate those different components that you think are important. The idea is that you want to identify the intervention and the approach to implementation that meets the optimization criteria. What does it take to get this implemented as efficiently and as effectively as possible so you have the greatest public health impact as well as sustainability of the intervention? You move through these phases with an ultimate test of your, quote, optimized model as you think through this. In a way, this is what we call an adaptive design. And in adaptive designs, we think of this as a planned modification of characteristics of the trial based on information, the data already accumulated. And that's from Hendricks Brown and colleagues. As data are collected, they're used to make anticipated choices about pre-specified alternatives. There are three types of adaptation as you think about this, relating to elements of study design of an ongoing trial, relating to the design of the next trial, or related to the intervention or its delivery. These are pretty abstract, but hopefully things will become a little more clear as we think about these. There may be a number of considerations as you're thinking about adaptive designs and SMART trials. Heterogeneity of practices and providers, barriers and facilitators that may or may not be observable, delivering the implementation strategies where needed, reacting to non-responsive or limited uptake, reducing implementation burden, so testing and identifying only what's necessary, and sifting through available implementation strategies. The idea with these are you're kind of honing in on what's needed. Not all clinicians or providers need the same supports. Not all organizations may need the same level of support in implementing new practices on organizational change or leader or champion development. There can be a large number of of issues that you can test in a smart design. So one of my favorite examples is a study by Amy Kilborn and Danny Almiral and colleagues looking at replicating effective programs to implement collaborative care using external and internal facilitation. I'll move right to the figure because I think it really tells us more about the design. So in this design, there's a run-in phase where all sites are offered intervention to implement evidence-based practice, and patients start the evidence-based practice early. And then you determine, are there responding sites or non-responding sites? For the non-responding sites, you add external facilitation versus internal and external facilitation. So it's adaptive in that you're identifying non-responders and you're saying, well, they're not just going to be non-responders that we don't know anything about, but we're going to add additional supports in the implementation process. This goes on again in the SMART trial because it's adaptive and you're using randomization, using a very systematic approach to really identifying what's needed or not needed for responding sites and non-responding sites as you go forward. Finally, at the end of this design, in this particular study, there's follow-up assessments at 18 and 24 months to look at how well practice was sustained and the supports that were needed. Another design that has been gaining a lot of popularity is the effectiveness implementation hybrid design. And this is one of those designs that's more unique to implementation science. So it says, we have a challenge in understanding the effectiveness in our interventions, but also the effectiveness of our implementation strategies. The hybrid designs allow us to have a dual focus on assessing intervention effectiveness and implementation strategy. The goal really is to accelerate the science. So we're not only focusing on effectiveness and then later doing an implementation trial, but we're able to do those simultaneously. As I mentioned, the difference between the effectiveness trial and the implementation trial, the test of the intervention alone in effectiveness versus the implementation trial, well, you're also testing the implementation strategy. Unit of randomization may be different for randomization and analysis, and outcomes are not only for the effectiveness of the intervention, but also the adoption and appropriate use of intervention, for example, looking at fidelity. So there are three types of these hybrid designs. The hybrid one is really testing the clinical intervention, an observational study of barriers and facilitators for implementation. Hybrid two, testing the clinical effectiveness, but also testing an implementation strategy. And then hybrid type three is really a test of the implementation strategy when we know the effectiveness of the clinical or public health intervention, and we're using either observational data or system level data to provide additional information on clinical outcomes and clinical effectiveness. These are very, very useful designs to think about, and especially when you're thinking about where you are in the continuum of developing in clinical intervention or testing that clinical intervention, or whether or not you just want to test the implementation strategy. A number of other methods that come out of system science. I don't have the time to go through all of these, but the top bullet, system dynamic models, uses computer simulations and also can use stakeholder engaged modeling of complex system behavior, getting input from different stakeholders about what's important. The example here from Doug Luke and colleagues, this example is around tobacco legislation and tobacco control policies and all of the things that were identified as potentially influencing those. Another system science method is using network analysis, or the study of relationships and flows among social actors. So for example, you could look at something like whether or not decision makers in service systems share knowledge about research evidence on addressing issues in public health, and create networks and learn about how those networks operate, and you could intervene in those networks to promote change. And then agent-based modeling, which is the use of computer simulations to examine elements of system behavior as a function of interactions with each other. So complex environments. I just wanted to highlight these as something to take a look at, especially where you have complex dynamic systems that you want to understand that may be nonlinear, and it may not, your question may not revolve around a hypothesis test per se, but may have to do with understanding processes and outcomes. So you might consider these computational modeling designs when empirical data are hard to get, but the interest is more in identifying and exploring behavioral dynamics and system feedback, or there are issues with units of analysis, or when it's difficult or impossible to do traditional empirical designs. These offer alternatives for these situations where you are interested in the dynamics of interactions of a process. Something that comes up very, very frequently is thinking about adaptation in implementation. There's often a focus on fidelity, and and what's meaningful for different stakeholders, fidelity to the intervention or adaptation for client populations, adaptation of context or implementation. So it begs the question of how designs can allow or promote or assess adaptation. One of the ways to document that has been put forward by Aaron Finley and Allison Hamilton colleagues. This idea of periodic reflections for tracking adaptation can be very important in understanding adaptations that occur and really tracking those and sometimes incorporating adaptations even in quantitative models. For example, if you have clinics that have a change in management over the course of an implementation strategy, you could create a covariate to identify that in a large-scale multi-site trial. You could also look at implementation strategies without adaptation or trying to control adaptation compared to implementation strategies with more controlled adaptation. And that's what was put forward in this dynamic adaptation process to implement this child maltreatment model, a study protocol that outlined a way to go about that and to have multiple stakeholders involved in not only considering what adaptations were needed, but also in tracking adaptations over time. And in thinking about adaptations, it's also useful to think about who the adaptation is meaningful for or important for. This recent paper really addressed the idea of identifying stakeholders, identifying the need for adaptation, and what that adaptation means for the degree to which adaptation and fidelity is balanced and how it fits with context. And in this model and approach, the idea is that implementation strategies can be a method to help create fit between EBIs and context, thinking about appropriate adaptations. And Shannon Sturman and colleagues did a really nice job of what they call the frame. This is really helpful in thinking about your design and how you're going to capture adaptation. For example, thinking about what is modified. Is it the content of an intervention or is it the context? At what level of delivery? When did it occur in the implementation process? Were adaptations planned? Just a number of things, way more than I could go into, but it's just helpful in thinking about how we track and consider adaptation in the implementation process. And then in terms of different outcome metrics, we're not always looking for group differences, but sometimes we're looking for equivalence or non-inferiority. And so this is just an example looking at the system-wide rollout of an evidence-based intervention. And the hypothesis of this NIH-funded study was that the subsequent rollouts from an initially trained team who trained other teams, so think train the trainer model, could maintain fidelity, or that fidelity would be non-inferior as the intervention rolled out across an entire system. And thinking about our study designs, we need to not only think about kind of the quantitative designs, mixed method designs, whatever, but also which variables are going to be key. And do we want to think a little more creatively about how these variables fit with different outcomes? The final thing I want to talk about is the idea of scaling out. This is an approach to adapting and delivering evidence-based interventions across systems and organizations or different target populations. The main questions here are whether scaling out, which is really taking an intervention that's been proven in one service system or with a population, and then testing it in another system or with a new population, and using data from previous trials to borrow strength from that previous study or previous studies as comparison for the new studies. The idea is that we may not always need to do a new randomized trial in a new setting, but we can borrow strength from previous studies. And the questions are, can we expect similar effects to those found in previous studies? And importantly, do the mechanisms or mediational pathways that we've specified hold in the new setting compared to previous studies? So it's just a new way of thinking about how we do trials, the efficiency of trials, and whether we can have cost savings and accelerate our learning about effective implementation strategies as we go forward. So I am going to skip through these, but as I mentioned, there are really just two main types of scaling out. There are three types, but the two that I really want to focus on are population fixed, different delivery system. You're taking the intervention to similar population and new system. So the example here is the delivery of a child maltreatment intervention tested in Oklahoma, but then implemented implemented again in a new service system that is very similar in characteristics, but with a new population. The other example is a delivery system fixed with a different population. And the example here is an EBI delivered to a novel population within a similar service system. The example is a smoking cessation treatment in the same managed healthcare system, originally tested with behavioral health patients and then implemented in the same or similar system with diabetes patients. One where population fixed, other delivery system fixed. We're starting to see some studies that are considering this approach as a way to build efficiency. Just a few take-home points. It's really fun to think about innovative approaches, but if they are relevant to your study. So thinking about SMART trials or most trials, the issue is making sure that your design addresses not only the intervention, but the context and implementation strategy. Considering efficiency, we're trying to improve that lag between intervention development and health impact. And I don't have it cited here, but there is some recent work by J.D. Smith and colleagues in implementation science that lays out an approach for logic models and how you use a logic model to identify some of these issues that can help you with your study design. We should always be thinking about context and how that fits in. If there are real-world rollouts where we could consider putting some parameters, either quasi-experimental or randomization in real-world rollouts, that involves engagement and collaboration with partners in systems and organizations where we really think of ourselves as a team rather than the researcher doing something to others. You can identify and rank potential study designs and then decide, but there is life beyond the RCT. There are just many, many designs to consider. So thank you.